Hi everybody, I'm Elisabetta Degasperi. I'm a hepatologist and I work in the division of Gastroenterology and Hepatology in the Foundation Policlinico hospital in Milan. In my everyday practice, I work mostly in the outpatient clinic and I'm fully dedicated to hepatitis B and Delta. In our center, we follow approximately 150 Delta patients and we are involved also in many clinical trials focusing on HDV treatment. Today we will talk about novel therapies in HDV. HDV is a defective virus that needs hepatitis B virus for propagation. It is the most aggressive form of viral liver disease, resulting in fast liver disease progression to cirrhosis and its complications. For decades, therapy with interferon has been the standard of care treatment, but resulted in low cure rates and had significant side effects. In 2020, EMA approved Bulevirtide for treatment of chronic hepatitis delta. Bulevirtide is an entry inhibitor, so it blocks the attack and entry of HDV into the liver cells. During these 5 years, clinical studies have demonstrated high rates of virological response, that is HDV viremia reduction, normalization of liver enzymes, improvement of liver fibrosis, reduced risks of liver decompensation, optimal treatment tolerability with few side effects. However, there are still some limitations. Treatment is not approved worldwide, has to be administered as a subcutaneous injection every day, needs to be stored refrigerated, and there is no established treatment duration. Finally, treatment is not able to significantly interfere with hepatitis B virus, which is the helping virus for HDV. For these reasons, new drugs are under development, and let's touch together these new molecules. Lonafarnib is a first oral drug against HDV. It interferes with viral assembly. Unfortunately, studies with lonafarnib show the lower than expected efficacy, and high rates of HDV suppression still require use of interferon, and there are gastrointestinal side effects. PEG interferon lambda was supposed to be a novel interferon with reduced side effects compared to classical interferon. However, the study with interferon lambda was halted due to some cases of liver decompensation potentially related to study drug. The most promising molecules right now are drugs that act by interfering with hepatitis B virus. Bulevirtide and todevibart are monoclonal antibodies that neutralize circulating virions, while elebsiran inhibits production of HBV particles. Bulevirtide alone, administered as a subcutaneous injection weekly, or combination of todevibart plus elebsiran administered as a subcutaneous injections once a month, showed excellent rates of viremia suppression and also strong reduction in HBV markers. These drugs are very well tolerated with only transient flu-like symptoms. Currently, large clinical trials involve these drugs both in patients never treated or in patients who failed to respond to Bulevirtide. These drugs are in advanced stage of development, and we hope to have them available in clinical practice in the next few years. Rep 2139 is a drug which interferes with HDV assembly and replication. It is administered subcutaneously once a week, but can also be administered intravenously. Recently published results from a compassionate use program in 33 patients showed high rates of HBV and HDV response, being safe also in patients with decompensated cirrhosis. Currently, we are waiting more clinical trials to confirm these preliminary results. So in conclusion, the field of HDV research on novel therapy is very active, and many drugs are on the block to provide higher chances of HDV and maybe also HDV cure. So stay tuned, and thank you for the attention.